name is Voigt. I am a physician and specialist in pulmonary and critical care medicine and in palliative medicine at Memorial Sloan Kettering Cancer Center, where I chair the Ethics Committee. Thank you for joining the second public webinar organized by the Empire State Bioethics Consortium. I am delighted to welcome you all to our discussion today. I'd like to make the point that I am speaking today only on behalf of myself, not as a representative of my institution. Likewise, everyone involved with the consortium who is on today's webinar comes to it as individuals expressing their own opinions and observations, not the viewpoint of their institution. I hope that our collective insight will be beneficial to everyone listening. On March 23rd of this year, at the beginning of the COVID-19 pandemic in New York City, a handful of bioethicists, clinicians, lawyers, and a few other members of healthcare organizations in New York State were witnessing a surreal, tragic, and distressing event. We felt alone and scared. We were exhausted and overwhelmed. We were grasping for ideas and solutions during a period of tremendous chaos and uncertainty, and we found each other. That first call became a weekly call, and our initial handful of participants grew to a much larger group that included people from several states across the country. After several weeks of deliberations, we created a public program to share ideas and wisdom gained from our pandemic experiences as broadly as possible. Once again, I want to welcome all of you who decided to join us on our second webinar on ethics consultation during COVID-19. Our goal is to ensure progress in how we approach this hopefully once in a lifetime challenge and avoid relearning the same lessons. We hope that the consortium will serve as a repository of knowledge that is shared widely and discussed among several other bioethicists and clinicians in many other states, and that it offers you and us practical solutions to the ethical quandaries that our communities have faced, are facing today, and may face again in the future. Speaking of communities, a parallel goal of the consortium is inclusivity. As we strive to make the voice of bioethics heard in New York State, we need that voice to reflect the full range of diversity that exists in New York State and in many other states. If you work in bioethics, please be in touch with Ms. Claire Murray at Murray, M-U-R-R-A-Y, C at mskcc.org. Please provide your email address and a short description of your work, and we will add you to our expanding group. On behalf of the members of the Empire State Bioethics Consortium, I would like to express my deepest gratitude to Amy Schaff, Claire Murray, Nadine Hazel, and Jennifer Polly at Memorial Sloan Kettering Cancer Center, and to the Columbia Master of Bioethics Media and Events teams, particularly Elizabeth Picard, Brendan Alexander, Peter Lee, Matt Van Helen, Jono Ori, and Michael Eder, for their assistance in making the webinar possible. Now, I am pleased to introduce Dr. Tia Powell, Director of the Montefiore Einstein Center for Bioethics and moderator of tonight's discussion. Tia?
Thank you so much. And my real gratitude to Dr. Voigt for his leadership in helping this fledgling organization, the Empire State Bioethics Consortium, try and find some useful activities to do. We hope that this webinar will be one. I will serve this evening as our moderator. I'm going to start by introducing our panelists, and then I'll make a few comments on the logistics for our work today. I'll introduce our panelists alphabetically. We are very lucky this evening to have a range of wonderful bioethics consultants. First up is Liz Blackler, who is the Ethics Committee Program Manager and a clinical ethics consultant at Memorial Sloan Kettering Hospital. She is a clinical social worker, and she is a graduate of the master's program in bioethics at Einstein. Next is Adira Hulkower, an attorney and bioethicist who is the chief of the consult service at Montefiore. Professor Hulkower is an assistant professor in the Department of Epidemiology and Population Health at Einstein, and an attorney with long experience in the Bronx Family Courts, among other places. Janet Malek is an associate professor in Baylor College of Medicine's Center for Medical Ethics and Health Policy, and the director of the Houston Methodist Biomedical Ethics Program, focusing on issues related to clinical ethics, genomic and reproductive ethics, and professional education. Dr. Prager, Ken Prager, is a professor of medicine, the director of medical ethics, and the chair of Medical Ethics Committee at Columbia University Medical Center. I will add on a personal note, I welcome old friends as well as a new one. Many years ago, Dr. Prager and I, both younger at that time, started the Ethics Consult Service and the Bioethics Committee at Columbia. And my predominating metaphor for that time was sort of Hansel and Gretel, kind of going through the forest, trying to figure out how we might be of use. So we cover the waterfront in terms of our institutions, and we'll start in 1 minute. I'd like to remind our viewers on YouTube that you are very welcome to submit questions or comments in the chat function on YouTube. We will begin with comments and a conversation and presentations from our panelists, but then after about 45 minutes, we will go to taking questions from YouTube. If you'd like to attend our next event next week, you'll need to re-register for that, and I'll come back to that at the end of our session. So let me begin now by starting with some questions. Let me begin by asking one of our panelists, at your facility, what special issues arose in patient-specific consults related to COVID? How did your practice change to accommodate working during the pandemic? Dr. Prager, would you be willing to take the first crack at answering that question? Dr. Prager, I think you're muted.
Sorry about that. I would be happy to start, and I think back wistfully to our early days together when Columbia's Ethics Committee started. Let me begin simply by saying that when the pandemic began, we entered into a new world. This was something completely that was not experienced by anybody in the New York City area before. And this was an experience, of course, that none of us were eager to engage in. The sheer number, the sheer quantity of incredibly ill patients who came to the hospitals was unrelenting, critically ill patients. And this, of course, changed the nature of the hospital. Our hospital basically became, in a matter of weeks, a COVID hospital. At one point, about 83% of all the inpatients at Columbia were COVID patients. And the nature of the ethics consultation service changed as well. We actually did a retrospective study in which we looked at the ethics consults from mid-March to mid-May this year compared with a year ago. The number of ethics consults quadrupled. We had 96 consults versus 25 the year before. 63% of those consults were in ICU patients versus 36% the year before. And many of the issues involved, and 63% of the consults were from the ICU versus, I'm sorry, I mentioned that before, versus 36%. So we were dealing with critically ill patients, and The physicians who called found themselves in, again, uncharted waters, being surrounded by patients who were on ventilators. At one point, we got a call in the middle of the night with 11 patients in the emergency department at one of our hospitals, 11 patients in the emergency department. And so the nature of the ethics consult service changed basically to an end-of-life service where we were looking at issues of medical futility, issues of goals of care, somewhat issues of triage, although we did not have a formal triage policy. And what we attempted to do basically was to be there and hold the hand, as it were, of the young physicians who were dealing with these critically ill patients. I think that we functioned in a manner that was extremely helpful to them, because being in the midst of the pandemic, surrounded by critically ill patients like that, it was very helpful to speak to somebody who was outside of the maelstrom, who could consider some of the medical and the ethical issues in a slower way, in a more resolved way. And so the ethics consultation service was, the reason that we got all these consults is that people felt that they were very helpful. And so this was, I would say, the broad picture. It was a increase in the quantity of patients that we have, and the nature of the consults, which all were basically around end-of-life futility issues and so forth.
Liz Blackler, would you be willing to have me ask you this same question? What kinds of changes did you have to make in your practice to accommodate working during the pandemic? You're on mute, sorry.
Thank you. Certainly, I think similar to Dr. Prager's experience, our ethics consults doubled during that same time period. And what we found is the majority of the consults were staff expressing concern about cardiopulmonary resuscitation and non-beneficial treatment in our advanced cancer patients. We learned very quickly and early that instead of, while focusing on the individual ethics cases, we also realized that we needed to provide support to the staff in real time. So in addition to all of these ethics consults that we received, we had to switch gears and focus on, in real time, on the ground education and staff and to staff. And so what we did was implement a series of formal and informal education programs at the bedside, in the nurse's station, and then virtually. So at some point early in the process, we came up with a plan to do a virtual ethics consultation service. So it's sort of like open office hours, where we manned 2 ethics consultants on a phone line to just answer questions. And you would be surprised, the staff would call in and just ask questions, want to hear what other staff was going through. We created this sort of camaraderie, this community that was so important. And ultimately, it reduced moral distress and mitigated some of the ethics consults because we were able to communicate in real time with staff. So in tandem to doing the individual consults, we really provided a lot of education to staff and support to staff in real time.
Fantastic. I love that idea of the office hours. Would either Professor Malek or Professor Hulkower want to comment on this, or would you prefer to move on to the next question?
Go ahead, Janet.
Well, our situation is a little bit different here in Texas, since we are just sort of entering the phase in which the sort of crisis is coming down on us. So our consult practices haven't changed dramatically up to this point, with the exception of 2 things. One is having to be remote. They did restrict the visitation, and so that really changes who is in the hospital. And we've also, as a service, and with, in consultation with our administration, decided that we were going to do most of our consult activities remotely. So that has raised a new sort of level of challenge in terms of communicating with patients and families, particularly with patients. Families, since they're not in the hospital anyway, it hasn't been as much of a challenge. And in some ways, it's almost easier to get a hold of them on the phone because more people have been available. but not being able to talk to the patients directly and not to participate in family meetings has been a big challenge. I think the second challenge has been the additional burdens that families of COVID patients have been experiencing. They have family who are sick. They're sick themselves. They're in the hospital themselves. They feel guilt because they were the ones who brought, COVID to their family member. And so an awareness of those different issues has been really important in terms of trying to make sure that we're being responsive to the needs of the patients and their families.
Sorry, Adira, did you want to add something?
Yeah, I wanted to sort of echo some of the things that have been said, and just to share that I think some of the expertise that ethics brought to the table is that we are very used to having conversations around uncertainty from places of uncertainty and discomfort, and normalizing uncertainty and discomfort. And if this is uncertainty and discomfort like none of our clinicians have ever known. And I believe that our fluency and ability to talk about these issues was very helpful to our staff. So the question that sort of came up was, how do we reach that staff? When you asked Tia about how did we have to change our practice to accommodate for the pandemic, part of the changes that we had to make was figuring out how to be present for staff and how to let them know we're here. So as Liz Blackler shared, she created virtual ethics hours. We had similar things in that we never had virtual ethics hours, and think that's a brilliant and wonderful idea. And I encourage all of you who are watching to think about instituting that in your institutions. But we did have an opportunity to meet weekly with house staff and residents with one of our hospitals, to meet with critical care, to be very present for the critical care team. And we could have even been more present by creating even more office hours, such as what Liz shared. And to meet with nephrology teams, everybody who was going through the uncertainty that comes with the questions of triage and end-of-life care. And something a little different happened in our institution. Our actual consults to our consult line decreased, but the request for bioethics presence in these for staff specifically, not necessarily for a patient-related question, but for overall goals of care, patient care questions, increased tremendously. And I felt that some of our most value added, our most significant value added came from those conversations that we had with staff and making ourselves available for them. And I think, Tia, we might touch on that further when we talk about issues of distress to staff. So I can sort of stop there, and maybe we can touch on that later.
Thank you. But actually, while I have you, let me mix up the order a little bit. And let me ask, and I'll let whoever else wants to answer this also jump in. But let me ask you, was bioethics involved in, apart from individual case consults, was bioethics involved in setting policy and helping plan the response at your institution or in other activities? And if so, what went well? And what would you love to do differently next time? So why don't you start, Adira, and we'll go kind of reverse order.
Okay, so the answer is yes, we were heavily involved. And we were very lucky that we had colleagues in our institution, one of our colleagues, Dr. Chung among them, who had been thinking about triage before the pandemic. So we had a foundational document that we could start looking at. So bioethics was involved heavily in looking at a triage policy, like Dr. Prager's institution. Ours was never officially instituted, and we can talk about why later. And we were heavily involved in that, but also, and I sort of stress this because I think that I'm concerned that the hyper focus on ventilator triage is still sort of trickling down to other states where they are working on policies around ventilator triage. And what we wound up seeing is absolutely ventilator triage is an important thing to be looking at. And we were lucky, we skated along at times, very, very close to the margins, but we were lucky that that never became an issue well, it was an issue in terms of which ventilators, because we were operationalizing certain ventilators that might not have been meant for the purposes that they were being used for. So it did become an issue, but there were a lot of other issues that reared their heads. And among them was dialysis, responding to shortages in both dialysis machines and staffing, high flow nasal cannulas, which we have learned clinically were very beneficial for certain patients. I want to share that I am not a clinician, so do your research on using high flow nasal cannula. Don't rely on me, other than to say that there is certainly a need for it and a resource scarcity issue. And how do we think about how we triage, or at least create a system for when it's initiated? And so we were involved as the bioethics committee, well, not committee, sort of our bioethics center, in helping create policies. Additionally, and very importantly, we were involved in supporting some of our critical care staff and other staff with communication scripts about how to communicate issues like to family members about possibilities of scarce resources, or when CPR would be appropriate, or when dialysis, initiating or terminating dialysis is appropriate. And so our little center was heavily involved in those conversations as well. And finally,
go ahead.
No, you please.
Well, I was going to say, why don't we stop you there and see if any of the other panelists want to weigh in on this issue of, was your team in bioethics consultation pulled in terms of policy issues? Anybody want to have a go? Okay, Ken? Yeah.
Very heavily involved in policy consultations. We had a daily phone call conference with high administration at the hospital, ICU representation, ethics representation, and legal. At first, we were concerned, we felt we had to formulate a potential of having a triage policy because there was a great uncertainty at the beginning of the pandemic in New York City, whether or not there would in fact be a triage policy that would be authorized by the state. And so we wanted to be on top of the situation and have our policy, have a policy ready to be rolled out if the state gave us the okay, if we had the legal protection. And a great deal of time was spent on that. And for various reasons, we never got the rollout. We never got the okay. There was never the legal protection for it. But certainly we spent a lot of time in formulating the policy, which is still on the books, if I may say so, but not actually being implemented. But what was implemented was policy dealing with futility in CPR. One of the commonest problems that we encountered initially and throughout the pandemic was people arresting repeatedly, people who had zero chance of surviving the CPR. And the ethical issue arose as to whether or not it was appropriate to attempt CPR at the request of families and thereby expose our nurses and doctors unnecessarily to aerosolization of the virus and potentially getting sick, as well as using up a precious PPE. And so this was a policy that was developed in due time with the four individuals that I mentioned on both campuses. And we did have a policy which we did implement. I must say that this was a great morale boost to our troops in the field, to our physicians. They felt that the hospital had their back on these situations, that the ethics committee was seriously considering these issues. And I don't want to minimize then the amount of morale boosting that having somebody consider what the problems are that were facing these individuals, and knowing that we were trying to help them, as well as helping the care of our patients by having these policies which would be helpful to patient care as well.
I just want to flag that as an incredibly important contribution. Having spoken to people at facilities across the state, and certainly at many, many different facilities in New York City, all of whom were hit very hard by the pandemic, not having such a policy was really unbelievably onerous for the frontline providers. They were getting different instructions from different people. We had at a lot of facilities, there were trainees brought in from different fields who were relying on instruction from different, more experienced attendings and getting different recommendations from different people. And that kind of unevenness in care is not the hallmark of good care we recognize in medicine. So I think bravo to your institution for being able to put that together. It was not done in every facility. And I think to the detriment of the care and of the ability of hardworking, desperately hardworking clinicians to do their work, do it well, and know they were doing the best they can. Other panelists who want to comment? Who else wants to jump in on this policy issue? Liz, yeah.
We at hospital administration looked to the ethics committee and consultation service to provide support and guidance and counsel along the way. So early on, our hospital initiated their hospital incident command center, and we had a seat at the table, and we're certainly looked at, and it was expected that we would put together different policies, including allocation policies, which we did. Ultimately, similar to Adira and Ken's experience, we did not have to implement those allocation policies, but we certainly spent a lot of time thinking about it and also talking about it with the institution. I think what was happening in the city and in the country is there was so much information and so much misguided focus on ventilators being the answer to things that the staff and the hospital needed to know that we were pausing, slowing things down, taking the time to think through processes just in case we hit this point where we needed to implement them. And that went a long way. So one thing I would say is that we were transparent. And so everything that we were doing as a consultation service and a committee was openly discussed in the hospital, both with administration and with staff on the floor, and that went a long way. And so I certainly would encourage as much transparency as possible through the process.
Janet, anything on this topic?
Yeah, sure. We had representatives from our bioethics committee and our biomedical ethics program also involved early on. We looked at what we had on the books, and it turned out that it was a mass casualty policy, which we quickly realized was not going to be sufficient for what we were facing. So we kind of scrambled around, and for a couple weeks, like those first couple weeks after everything shut down, put together a triage policy within our institution. We're also situated in the Texas Medical Center with many, I don't know the exact number, but like many hospitals within a very small geographical area. And so we also realized that it was going to be important to connect with the other hospitals there. And so a work stream began among the various hospitals, and it was a great collaboration amongst all the ethicists in this area, being able to say, we are going to work together to create a document that maybe isn't as granular as the individual institutions, because they may have different needs and preferences, but at least we can say this is common amongst all of our hospitals to try to know that we wouldn't have great variation. You know, oh, you go down the street and you can get a different set of, you know, live under a different set of rules. So I think that that was a victory, sort of a collaborative victory for our organization, or for the Texas Medical Center. Yeah, I wanted to follow up on what Liz said about transparency. I think that has been a really interesting point for us as well, in that we have all of these policies and sort of plans in place, and nobody's really sure if and when we're going to need them. And so there's a bit of a tension there between, we want to make sure everybody knows that we're prepared, we have plans in place, but we don't want to freak people out too much by advertising them and being overly transparent. And, you know, the TMC has done a great job of giving information about ICU levels and everything every day. And at one point, it was kind of like going into the red zone. And I think people started to get nervous. It started getting covered in the papers that we were out of ICU space. And then we sort of realized, wait a minute, is that the right way to be framing this? Like, we have plenty of capacity. We've been preparing for this for months. So they kind of reorchestrated the communication surrounding that to say, we have this phase 1, phase 2, phase 3. So we're definitely feeling sort of the tension there between being prepared and transparent, but not wanting to sort of put things in place prematurely.
That's a really important point. We may come back to that when we talk about, if we talk about triage a bit later. It was a big issue for us in New York, I think. Let me, oh, Adira, yeah, sorry.
Okay, if I just pop in with 2 points.
Yeah.
One is just because I think a lot of what we want people to walk away from is practical things that they can use in their states and in their institutions. So first, I would share, I believe Dr. Prager did this in his hospital, but we had weekly meetings with risk, legal, bioethics, and the Office of the Medical Director. Every single Wednesday we met and we discussed what was happening, what each of us were hearing from our different people. And it was a space where we were actually able to say, I met with the residents yesterday, here is what they're experiencing, what can we do as an institution to support them? And we had everybody's ear. And having all of those people in the same room in a collaborative fashion, first of all, was an incredible time saver to not have to sort of navigate all those phone calls and trying to reach everybody. But it also created a situation where people were able to sort of, our different institutional leaders were able to share freely what are the obstacles, is there a creative way that we can go about them, and how can we quickly collaborate in order to meet the needs of our staff. So I wanted to share that as one idea. And the other thing that comes to mind, and again, I speak for myself and not for my institution, is that, and this came up for me listening to Janet speak, we might say that we never had the need to institute a triage protocol, but that might indicate that our triage protocols were looking at too severe situations to get started, right? So if we were using particular ventilators or if hospitals, let's say this, if hospitals are using ventilators that are meant to be used only in a particular situation, and they're being jerry-rigged to be used as an appropriate ventilator for a COVID positive patient, that might indicate to us that we don't have enough ventilators, actually. We're trying to create ventilators that are useful, but maybe we don't have them. And the same thing goes with not factoring in trained staff and education as part of the resources when we think about scarce resource allocation. So we might be on the cusp of having enough dialysis machines, but if we don't have enough people to run the dialysis machines, or we don't have enough educated nursing staff to be at the bedside for particular patients that maybe need monitoring for peritoneal dialysis, then we don't have enough dialysis machines because we don't have enough people to support using them safely. So I just say, like, as we look at the things and when do we enter into like the red category of necessity, it might be important as you're creating your triage protocols or looking at your triage protocols to say, does this triage protocol kick in soon enough? And what do we consider a scarcity of resources?
Very helpful, thank you. Let me ask the question. A number of you have made reference to the comment of how distressing clinical care, of moral distress in the providers. What, and to some extent you've addressed this, but what aspects of the pandemic and your experience created moral distress for providers, for patients, for their families? And what resources were available at your facility for support? And what would you like to see? What would you recommend to colleagues who are in places where maybe things are heating up now and things they might like to put in place? Who would like to take that? Yeah, Liz Blackler.
I think the anticipation of scarcity was palpable at the institution. So, our staff members, they would see you and are we in a level 1? Do we have ventilators? Do we have enough PPE? Where are we with ICU beds? It was profound. And I think just the anticipation of what was coming next. They're here working all day, but they're listening to the news at night. They're listening to Governor Cuomo. They're watching what's happening, and they're uncertain about how it's affecting the hospital and their day-to-day patient care. And so, just acknowledging that with them, and similar to what Adira was talking about, this idea of we've got these plans in place that we can implement it at any moment, but is it time? And so we would get consults from staff members questioning whether it was time to to consider who who would get an ICU bed, or if a ventilator was appropriate for a patient, in anticipation of not having enough resources. And so, how do we mitigate that? Part of what many of our institutions did, and we've already talked about it, is just that daily rundown. We have X number of patients in the hospital, X number that have COVID, X number in the ICU. This is, the stats for the day. We have enough PPE. This is how, this is the way to use them appropriately. I think helped, along with the consultants being present both virtually and, in real time, helping to mitigate the stress. I would say the other thing, what was moral distress for both staff and patients was the visitor restriction policy. So we had patients were alone, and staff was in and out of rooms trying to provide, not only providing nursing support and day-to-day medical care, but also trying to support and be quasi-family members and caregivers at bedside, trying to connect family to patients in the rooms. Most of our patients were on isolation. And so behind closed doors, nurses would be, knocking on doors, looking through the windows, trying to get patients to answer the phone so they could talk to family members. And that was heart-wrenching. So I do think, when we think about a surge or what's happening in other states right now, is there a way to safely allow patients at bedside, our families at bedside, through this process would be incredibly helpful and just more dignified, because many patients died alone. And that is a heart-wrenching experience for not only patients and families, but for our staff.
Terrifying. I mean, certainly in the cancer hospital, but for many older patients, particularly those with cognitive impairment, either chronic or acute, it was terrifying to be alone without a familiar face. The risk of having additional people is significant, but I agree it's a big problem. Ken Prager, did you want to comment? Yeah.
I think the moral distress, really stemmed from the fact that society made a decision by not allowing triage policies, by not giving the legal protection for it. The only other way then to deal with a inundation of critically ill patients was to expand your ICU facility. That involved in our hospital virtually tripling the number of ICU beds. That means spreading your staff thin, your doctors, your nurses. And so for a nurse having to take care of 2 patients, which was the normal ratio in the ICU, she or he would have to take care of 4 patients. That creates moral distress. For an attending physician to have to be responsible for 30 or 35 patients in an ICU setting, that creates moral distress. For a GI attending to assume the responsibility of working in the ICU, where he or she has not had experience for quite some time in dealing with patients on ventilators, that creates moral distress. And one of the jobs, shall I say, or one of the roles of the ethics committee, as I said before, was to legitimate the feeling of distress, but to tell them that this is not your fault. You're doing the best that you can. These are the circumstances. We are doing the best to provide you with as much support as possible. But the fact that you cannot replicate the normal standard of care, perhaps for many of these patients, is something that is unavoidable under the circumstances. So I think that was the largest area of moral distress. Then, of course, there was the issue of futility and being bound by legal provisions that would not allow more autonomy on the part of physicians to make decisions about, for example, DNR and DNI, and having to expose themselves unnecessarily to futile procedures and the aerosolization of the virus. That created distress as well. And as was mentioned before, there was the distress on the part of families by not being able to visit the patients. I think that it even created distress on the part of the physicians who are used to having family at the bedside advocating for their loved ones, and just having an entire ICU filled with bodies, with patients, without family visitation creates a surreal type of environment, which was extremely unsettling for many of the physicians and nurses. One way that we attacked this was by employing palliative care service in a very, very aggressive and expanded way. And we used our palliative care service physicians and nurse practitioners and social workers to call up the families. They were the point people very often in trying to make the bond between the family and the patient lying in the bed, using the visual means and so on for enabling them to see their loved ones. I think the role that was played by palliative care was extremely helpful in alleviating some of these issues of the distress of families and not being able to be with their loved ones.
Thank you. Adira, yeah.
So there's a moral distress and emotional distress and all the different flavors of distress, I think, that were manifest during this time. So moral distress certainly from our staff and the inability to provide the care that they believe their professionalism demanded of them. And there's no way to make that better. And there's no way to say this is good care or this is best care. We have to sit with the fact that because of the circumstances of the surge, care was compromised, and to be open to discussing that. From the perspective of the patient, I have been talking a lot about how, talking a lot to whoever will listen about how the tools of clinical ethics, of the clinical ethicists were really sort of taken from us in certain ways, like the tool of the family meeting, the tool of the interdisciplinary meeting where we sit at tables and we look at each other. And I don't, yes, Zoom is fabulous, but there is just no substitute for sitting in a space and sharing a space with other individuals and being able to read their bodies and to read their facial expressions and to match their tones with what you're seeing. And I've been talking a lot about how I sort of felt like those tools were taken away from me, but it just now realized that I haven't been talking a lot about how that was taken away from the patient too, right? What was taken away from our patients as well was the ability to read the faces of their clinicians, to touch their clinicians in any way that is like, it was only necessary touch. It was only necessary contact. It was only necessary dialogue. Everything became sort of pared down to what could we do the fastest and most efficiently to provide the most basic care to the most people. And unfortunately, something that gets lost then is the sitting at the bedside and the holding the hand and the getting to know the story of the patient. And that, to me, I think caused moral distress for the staff, but certainly a level of emotional distress for our patients. And when we add on top of that, the alienation from family, and it's like compounding heartache with heartache in a lot of ways. And our hospital certainly worked super hard to try to figure out how to bridge those gaps when our policy was not to allow visitors. There were always certain categories in end-of-life care where we were trying to allow visitors throughout, but through some of the ways we tried to alleviate that was, as Dr. Prager sort of referenced, having iPads or Kindles purchased so that there could be FaceTime with families. And we ordered, one staff member said there aren't enough chargers, and our hospital put in an order for hundreds of chargers to be available so people could continue to charge their phones and be able to use their phones to contact family. These are great things that were done. It is no substitute for family member sitting at your bedside and being your advocate. And I'll just add one.
It's a good practical suggestion, though. It's very helpful.
And I'll just add one more space from the flip side of where we saw the distress of the surrogate. There's a lot more distrust, or at least trepidation of, are they telling me the truth about my loved one? Are they once you start seeing news media reports and reading about the potentials of triage protocol and the scarcity of PPE and the scarcity of other equipment and interventions, family members are reading and hearing that and saying, how do I know that my loved one isn't getting the short end of the stick? And so there are some hesitations about consenting to end-of-life related withdrawals of treatment or palliative care, because there is a growing suspicion that my loved one might be the victim of some sort of triage. And also, and this is the last point I'll make on this, we saw something that particularly struck me were family members that saw images of refrigerator trucks with bodies in them and said, that's not how my loved one dies. That's not their end. And so they were resistant to adopt to certain end of life care that may have even been consistent with their own values and the values of their loved one, because that was not a dignified demise for them. This is not dignified to die without your family. This is not dignified to be in a refrigerator truck. This is not dignified when I hear about bodies in morgues that are piling up. And I can't be at the bad side. The best I can do is to dig in my feet and advocate from my home to delay the inevitable, because maybe then I'll get to be with my loved one. And all of that, I think, was the distress that some of the distress we saw from surrogates. And so you compound a distressed patient, a distressed clinician, a distressed family member, and you can sort of see like this seed that needs to be navigated in terms of being empathic, thoughtful, and process oriented.
Thank you. It's very powerful. Any other comments on moral distress? I think I'll summarize. I know a number of you mentioned the enormous distress for clinicians because they can't deliver ordinary care, the standards that they were trained to deliver. And I think actually if there's any single teaching point that you can offer to people who, as they move into the state of public health disaster, it's that things change. Crisis standards are not the same as every day. It isn't your fault. It's not possible to deliver ordinary standards of care when you're in the middle of a public health disaster. When the hospital's on fire, you do things differently than when it's not. So I think that as a teaching point is incredibly important. Everybody loses choices. The clinicians don't have a wide range of choices about what they can offer you, and patients and families may not have the same range of choices about what they can ask for because the hospital's on fire. It doesn't mean that we don't try and do what it doesn't mean we don't have to really think about bias and make sure we're being fair, but it isn't ordinary care. And that's not the fault of the clinician who can't do things exactly in the way they were trained to do it. I think that for me would be one single crucial teaching point to offer people. I'm going to make a move. We're about halfway done, and that was kind of our mark for when we begin to take questions from the listeners. And we have quite a few questions. So I say, let's dive in there. We have some other things too, and I want to make sure you guys all get a chance to bring in your points. But let me pick a few questions and we'll sort of go from there. There was a question, was the focus on ventilators a problem nationally? Let me see if I can find this. Was too much reliance on ventilators a national issue that we have learned from? That's a question from Jared Silberman. Does anybody want to comment on that? Was there too much focus on ventilators?
I don't think there was too much focus on it, but I think at least in New York, it did not turn out to be the pivotal question. There were enough ventilators. As Adira said, not all of them were of equal quality. We had to jerry-rig some others. But I think the focus on ventilators sort of was the focus on triaging. That was the focal point for what if we don't have enough ventilators, what then, who will get the ventilator, and so forth. It turned out not to be the issue. What really turned out to be the issue was the shortage of personnel to man the expanded ICU beds. That's the shortage, human beings. It was the human resources that was the shortage. And whether or not the focus on ventilators actually detracted from that or not, I don't think it mattered. Everything was done, obviously, to try to get as many trained people as possible. We made efforts to get people from out of state. Nevertheless, there were a significant number of people who were recruited from within the institution who were working in areas that they were unaccustomed to. But as Tia said, we were doing the best that we could. And in the future, is there a way of training people more quickly to get them up to snuff to be in the ICU, or ways of having lists of people who could be recruited from out of state who might be helpful to fill the shortage of human resources? Perhaps so. I think that would be an appropriate thing. But
I think that's a very practical tip, that when you're going to be drafting the orthopedic surgeons to work on the medicine floors, it would be fantastic to develop some quick, it doesn't make a doctor out of someone who's not a doctor or an advanced nurse practitioner, but if you give some specific guidance on what pain medications are effective under this circumstance, you know, a few things that would be very helpful. Those could be drawn up in advance and be a sort of helpful cheat sheet for people who are working out of their comfort zone. Other comments? Yeah, Liz.
I would say that's exactly what we did at the hospital. And so early on, when we realized we were going to be opening a second and a third ICU, we started virtual training sessions where our critical care medicine attendings met with the anesthesia physicians, the hospitalists, and the other physicians that had been drafted to help work in our new ICUs, and did a series of educational workshops, 3-4 hours every day for a week. And certainly part of those workshops, so our supportive care, our palliative care service came and gave a really thorough and thoughtful discussion on how to have end-of-life conversations with families. So in addition to just talking about how to manage a ventilator and the medications that go with that, the clinical care, supportive care came and talked about end-of-life discussions. Ethics presented, and we talked about what was happening both at a national, state, and local level, and what we were doing as an institution from an ethics perspective. And I think, you do the best you can in real time to provide your staff with enough information and education and with the knowledge that you're not alone. So every newly drafted ICU attending had a mentor that they worked with, someone that they could call at any time to ask questions and make sure they were doing the right thing. And so I think providing the support and the education and the knowledge that there was always somebody there to help you was invaluable.
Okay. We have another question coming in for all the panelists. This is from Andrew Oppenberg. Yeah. Could you please discuss your relationship with risk management and legal? Was it helpful or not? Any comments on that? Ken, yeah.
I just want to say one thing on the last question before going into this briefly. We have been focusing on what are things that we can do in the hospital to make things better next time for the next surge. I think we ought to also say that hopefully our government and our departments of health have learned something from their roles in the pandemic. Only yesterday, there was an article in the newspaper in the Times about how a hospital at the tennis court in Forest Hills was basically empty during the surge. There was not an efficient utilization of resources that were available. So let's not just talk about how the hospitals can be better. Let's talk about how the states can be better and the departments of health can be better and learn lessons from this. We need help from above as well. Now I'll segue into your next question was about the legal people. Yes, as I mentioned before, during the surge, we had daily meetings with the hospital administration, ICU, and with legal. So there was a very close relationship. If there were ever any questions about new ways of approaching certain pathways and we needed the legal input, we would obviously turn to legal. And they were intimately involved, as I mentioned before, in elucidating a policy to deal with the issue of futile CPRs. So I think there has to be, obviously, you want to do not only what's ethical, but you want to do what's legal as well. Or putting it the other way, you don't want to do something that's not legal. So yeah. I think a close collaboration is critical.
I agree, although I observe that across the country, there's enormous variation in the quality of the relationship between people in risk and legal and people in bioethics. Does one of the other panelists want to comment on how to foster good, effective relationships?
I inherited a service where those relationships had already been sowed by my predecessor, Dr. Lippman. But I have worked really hard to continue to foster those relationships during non-COVID times. And it was very natural and symbiotic sort to say, okay, I think I mentioned this already, so I don't want to repeat myself, just to say that I think a way to work on this is to start including risk and legal in some of the smaller discussions It doesn't, don't wait for the catastrophic discussion, you know, work through some of the smaller issues to start building those relationships, even in the midst of the pandemic, where you're going to have those bigger discussions. But I think sort of creating those weekly meetings, getting to know each other as individuals and sharing the aims, the goals, because ultimately, even though, at least in our hospital, and this time I do speak for our hospital, even, or for myself about our hospital, even though we have different jobs, patient-centered care is really at giving the best possible care to our patients is really what all of our risk legal staff members want as well, and ethics as well. So when we sort of put our heads together and think about the greater goal and having a common interest, we're able to accomplish a lot.
Thank you. We have a question.
Also had a very positive interaction with our legal team. I think throughout the course of this, they were involved in the small group who have been, you know, working on developing the policies. And we recently have had some discussion amongst our internal clinical ethics team. What do we do, you know, if there is conflict between the law and ethics, and how should we as ethicists resolve that question? There are a couple of laws in Texas that can put providers in difficult situations, particularly with respect to DNR orders. And so we've had to work closely with legal to help try to thread the needle on those to find a compromise that is both legally and ethically acceptable.
DNR creates a lot of work for ethicists in every state, I think. We have another question. This is from Carol Sheridan, a very experienced nurse who I know well. Carol Sheridan asked, does anyone think that the COVID experience will change our society's willingness to have advanced care planning discussions with patients and families with multiple chronic and/or terminal disease? What do our panelists think?
I'll take a shot at it.
Okay.
I think that I think that there are some people who are just immune to thinking about the end of life, and under no circumstances, regardless of what happens in society, there are just people who just cannot face their own mortality, will not fill out wills. On the other hand, there may be some people who were waffling about it, yes or no, and I think that hopefully that this will be a catalyst for a number of people in the middle ground to speak to their doctors about advanced care directives and so forth. I think it can be a positive influence in that respect, but I do think that there are some people who just, no matter what, will not think about the inevitability of their demise. But it's an opportunity also, I think, for physicians to bring up the issue in kind of a diplomatic way, in a non-threatening way, to raise it, given what's going on in the news, and we read about all these things happening. So perhaps it's an opportunity for some physicians to raise these questions with their patients.
Adira and Liz, did you have a comment?
Yeah, I'll take a stab at this. So I would say certainly, as a society, we don't like to think about, let alone talk about our own mortality. Working in a cancer hospital, one would think facing an advanced cancer with or without treatment options, you know, you start thinking about what may happen as one's nearing the end of life. And I would say, interestingly, our experience at the hospital was that many of our patients don't like to talk about it, even in the setting of an advanced cancer, and with all of the right tools and the right support systems in place. And that given the opportunity to try one more treatment or one more intervention, whether it's the ventilator secondary to COVID or dialysis or another chemotherapy, are very much wanting to be that 1% or 10% of patients who will get better. And so not surprisingly, in the setting of COVID, although we really implemented goals of care conversations with most of our patients who were admitted to the hospital, although some were reticent about wanting aggressive treatment, others were able to make a decision that, okay, if I'm not going to make it, I'd like to give my opportunity to somebody else. So I'm saying two things. I think as a society, we don't acknowledge our own end of life easily. When you add comorbid diagnoses like advanced cancer, what we experienced is that patients were still hopeful. Families were hopeful. They, like, as Adira mentioned earlier, they wanted to be at bedside. They wanted to make sure their loved one had opportunities. And so I'd like to think it would get a little bit better. We would do more advanced care planning, and I'm not sure. So we'll have to wait and see.
Janet, were you raising your hand? Yeah.
Yeah, I think this dovetails with one of the most interesting conversations that has taken place with respect to all of this, the questions about prioritization, which is, this question specifically talks about people with multiple chronic and or terminal diseases. And I think to some degree, and because a lot of the initial triage policies sort of excluded this population from, or proposed excluding or deprioritizing people who fit that description from getting the top priority for triage resources, I think there's kind of been a groundswell of support for those people facing those sorts of situations. Some way conversations, or to initiate those conversations with this certain subset of people. So I think it's going to be very interesting to see how that dynamic goes. And I'm not confident I have a good sense of that yet. I could see it kind of going both ways.
You're muted, Tia, but I
Yes,
think you're. So I think I just want to reframe Carol Sheridan's question, and I know Carol Sheridan very well, to just say also, will doctors learn to have these conversations better and prioritize them, and will, so I do think that there's going to, I agree with sort of the comments that I've heard. I think that there's going to be a reaction of some people to say, okay, I need to start thinking about this. I saw my young relative, I saw somebody who was young, you know, who didn't have any comorbidities become ill, and now I'm going to think about this. And I think we'll also see that arc, hopefully, if this pandemic ends, we'll see the arc where people start believing in their own immortality again and sort of push it away. The question is, how do our clinicians and our primary care clinicians, our specialists, use this moment to start becoming more, and I'm creating a big group, right? There are some clinicians that are wonderful at this. There's some clinicians that are terrified of this. You know, I always give the example of once seeing a cancer patient who had 19 different contacts with specialists with metastatic cancer and never once had an advanced care planning conversation. So it is not, I will not only put it on the patient to say it was the patient's duty to say, hey, I'd like to have this conversation. There were 19 other specialists who should have had that conversation with this individual before they wound up in our hospital. So I do think that this is a time for those of us who are champions of advanced care planning to be reaching out and saying, what support do you need to feel comfortable having these conversations internally within our hospital, externally within our outpatient clinics, or I should say in an outpatient clinic, and with other like community-based organizations as well.
Okay. We have a question from Tim Kirk, who says, I'm very struck by the emphasis on supporting clinical staff, which is no doubt important, but the patient's voice and values are paramount in case consultation, no? How were patient values elicited and engaged? What does the group think?
Yeah, well, I can start by saying that given the circumstances, every effort was made to contact relatives of the patients. You heard about the difficulties, and without the visitation policy, without having families there, this was sometimes very difficult. In every single case, when there was a patient who was incapable of relaying their own preferences or their own wishes, in every single case, an effort was made. And we had actually teams of people whose sole responsibility was to reach out to the families, to call the families, to find out about the patients as much as possible. What type of person were they? What were their values? What would they have wanted? This is assuming that the patient comes in without an advance directive. And the vast majority of people came in without advance directives, critically ill. We did not have that. We did not have that assist, that ability. So we made, I think, very strong efforts to try to reach out to families to know what the patient's wishes were. And more often than not, the patients were in no state to have a meaningful, calm discussion about what their wishes were. It was extremely challenging, but I think that all of the hospitals made, at least all of the physicians in our hospital made a significant effort to try to get to know what kind of a person was this, what would they want, were there any advance directives, etc.
Panelists, how do you elicit patient values during a public health disaster?
Yeah, and I would add to that, how during a public health disaster, when sometimes you're focusing on public health, do you tell a patient that their values are as important and completely matter, but we might not have the thing for you, or you might not get the thing? And what does that conversation look like? And how does that factor into sort of our conceptions of autonomy that are so alive within our medical, our healthcare system? And that's something that I haven't seen the perfect script for that conversation yet. That's something that I think we all need to keep working on.
Yeah, I mean, as I said earlier, that the circumstances of the pandemic really constrict autonomy, both for clinicians and for patients and families. You may want dialysis, I may wish to give it to you, and neither one of us may get what we want. It simply may not be possible depending on what else is happening around. It's a very difficult question. Any other comments from the group on that question?
I'll comment and say, yeah. Our practice changed. You know, we are clinicians, we're trained to go into the room, sit down and talk to the patient, talk to the family, find out who they are and what their wishes and values are, and then try to help advocate and apply those wishes and values to clinical care. And we were not able to do that in many cases. In general, patients were not alert and oriented, or they were delirious and not able to really participate in a conversation. And many of our family members who were home were also sick, or we were unable to get in touch with them, or were so distressed and not being able to be at bedside that it caused it was very, very hard. And so it was not business as usual from an ethics perspective. We were not able to do what we are so good at, which is soliciting someone's wishes and values. We're combing through charts, talking to staff, talking to family if we can find them, to try to piece together a plan. And it was much harder to do than during normal times.
Let's take a question which is related actually in theme, from Tracy Borgmeyer. Have you encountered families whose decision-making was crippled by mistrust from rampant mis or disinformation and conspiracy theories? How did you overcome this?
We've had a couple of really difficult cases where, for either mistrust of the medical team or mistrust of scientific information, you know, this idea that this COVID thing is all new, nobody knows anything, you're telling me this, but how do you know that? There's not enough information, you don't have the expertise, nobody does. And they have been some of our most challenging cases over the last few months that have taken hours and hours of work. I think our technique has typically been to be very patient, active listeners, trying to get them so that they know that we know what they're saying and what their opinions are. And then trying to find them somebody, whether it is somebody on our team or whether it's a chaplain or whether it's the palliative care folks, somebody who they can connect with, who they can trust, and then try to channel basically all of the communication with that family through that individual, so that when you're working with a family who has that loss of trust, it can be a bit of a minefield, right? You don't know what it is that's going to blow up in your face, and making sure that that one person knows the rules and knows what to say and what not to say has worked relatively well in some of our cases. I guess that's about the best we can hope for.
It's as good as it gets. Other commenters on that one?
Yeah, I would just say that here palliative care played a tremendously important role. Once again, I'll bring that up. I can tell you that one of our palliative care doctors once had a Zoom meeting with 20 members of a particular patient.
Wow.
20 members talking about end-of-life issues and so forth. They actually published a paper about the results of many of their interventions. And I mean, unfortunately, the metric by which we sometimes judge this is how many patients, how many families could we get to agree to a DNR order? That's kind of a morbid metric, is it not? But I will say that it's appropriate given the circumstances, given how sick these people were, trying to prevent them from undergoing interventions that would be of no benefit, that would cause them suffering, that would take the time of physicians who are struggling to save those people who are salvageable. This was a noble task. But I can tell you that when done sensitively, and time, of course, it took a lot of time. In many cases, certainly not all, they were able to garner the trust of the families of these patients. This is a Herculean task when the families can't be at the bedside and their loved one is dying. But I think our palliative care people were absolutely heroic in the work that they did there. And hopefully this can be emulated in other hospitals as well.
Okay, Adira, I think you were going to comment.
I want to react to something that Ken just said, and then I want to add. So one thing I want to say is, if we were able to have, and it sounds like Columbia did sort of get there, but in general, appropriate guidance from our government and able to institute real solid futility, and I don't even futility policies in situations where there's absolutely no physiological benefit to CPR, we wouldn't have to have a metric of measuring this kind of success to be whether or not people consent to DNRs. Because when becomes the focus of the conversation, it to me can sometimes like, so this continue to sort of like grow the seeds of mistrust when it seems like we're singularly focused. And that's why palliative care doctors who are hopefully so wonderfully trained in these conversations can help foster connection and engage the family members beyond the DNR conversation. Unfortunately, palliative care is a scarce resource too. And if we can't figure out how to make palliative care not a scarce resource, or we can't figure out how to train our medicine staff in palliative care and communication skills, then we're going to continue to have this problem of sowing the seeds of distrust, of mistrust, or at least I would say like growing them. And the other point that I kind of wanted to actually totally just point on the question, on the initial question, now that I had that sort of responded to it. What was it, Tia, that I was answering as I'm having that sort of blank?
Managing patients who've lost trust.
Oh, yes. The other thing that I wanted to say is that we have to validate the truth in that, right? Like the truth in, we don't know a lot and we're learning a lot. And when they say to us, well, this science we heard yesterday, and today you're saying it's not, I mean, it doesn't happen quite that significant like that obviously, or that black and white, but there is something to the distrust, right? These are not just challenging, difficult families. I still don't know if I turn my face to the right when I hug my mom and we're both in masks, like, is that okay? I don't know, because I read and nobody has told me what's okay or not okay. And so I try to err on the side of caution and I do all these things, but there are so many things that I have huge question marks about. And I am a person who is not a clinician, but is medically fluent and tapped into the newest information that's coming out. And I just don't know. And so I think when we work with these families, validating the space of uncertainty and distress that they come from is incredibly important towards fostering relationship.
That's true. As clinicians, we don't like to admit uncertainty, but man, there was a lot of uncertainty related to COVID. This was a new illness and it was a bad animal. And we really didn't know all of the manifestations that would have. They were quite right to say, you don't know everything about this illness. Let me move, I'm going to combine questions from two of our listeners. We have a question from Rosemary Purley-Qualk, who says, Our priest was allowed in for last rites only because he had already had COVID, but it meant so much to everyone, and several patients died while he was there. And Virginia Day asks, could we please comment on the role of the chaplain during COVID, and was it different than in other times in terms of ethics consults? So the role of clergy in helping during the pandemic, during your ethics consultations. What do you think? Adira?
I'm not, I want to admit to not being completely knowledgeable about exactly the role of clergy within our hospital. I do know that the palliative care clergy was available by phone for phone consults. They were, as far as I know, I don't know if they were in the rooms. But I do think combining those two questions together really helps us think about who is an essential worker, right? And how much are we looking at the totality of a human when we say, the human and the patient experience, when we say, you are essential because you know how a kidney works, but you are not essential because you know how someone's spirit operates, or how to touch their spirit and help bring that out. And there are some realistic reasons why that needed to be in certain points. But maybe as PPE becomes more readily available and we know better how we can protect our personnel both from receiving COVID and from spreading COVID, because that was one of the issues in terms of people entering rooms, was that whether or not they would then bring the disease out and continue to spread it. The more information we have on how to protect individuals, the more expansive I think we need to be about who we consider essential.
At Methodist, our chaplains stayed in the hospital much longer than our service did. And so we actually interfaced with them quite a bit, trying to, when we needed to go in and have a difficult conversation with a family or a patient that we were not allowed to, or we weren't supposed to go in and talk to, we would sometimes connect with them, and they were allowed to go in and talk to the patients when we had been asked not to. So I think eventually they did actually ask them also to try to do most of their work remotely. But for a period of time anyway, they were a helpful liaison for us.
You know, I think it's interesting, this idea of which workers, which disciplines are essential and need to be at the hospital at bedside, and which can perform their duties from home remotely. And so at some point, I'm not quite clear on the timing, many of our supportive services went remote: chaplaincy, social work, psychiatry was at bedside, but clinics were remote, supportive care was remote. And so looking back on that and thinking about how to do things differently in the setting of having enough PPE, I do think it's important to have those support services at bedside included. And I would include ethics in that, because there's value in being present for patients, being able to talk directly to families and say, I'm here looking at your loved one, or, you know, families at bedside, and being with the staff members. And so, you know, words of wisdom for next time is figuring out a way to have as many of those supports at bedside. One other comment is that several of our ethics consults were from staff who was frustrated that these important services were not at bedside, and that how can, you know, why are we here at bedside, and we need the help of our resources, our support staff that is so integral to the day-to-day care of advanced cancer patients, and they're working remotely. So, you know, wanting them to be at bedside because they're so helpful, and also dealing with the frustrations of being disconnected and trying to figure out how to Zoom and do all of that was one more added stress in the middle of a really chaotic situation.
Okay. That actually dovetails with a really important question. Karen Ann Sobek asks, if and when the second surge happens, or you get the continuation of the surge that you're in, what is the main thing you would do differently? What do people think? We've had some comments already, I think, but what else, anything else to add?
Yeah, I think from our perspective, we're sort of facing this right now, which is, as I described earlier, we kind of wrote our policy as the triage policy or the prioritization policy, and it only really covered crisis standards of care and critical care resources, and sort of saw that as a one single thing. Whereas I think we are learning from experience that that is not one single thing. And there's a lot of nuance in the prioritization guidelines that we need to be effective. I'm very worried that what is happening and what I'm hearing described happened in New York is that there were a lot of decisions that were made about prioritization that never went through any sort of formal review committee because it never raised to that level of the official triage policy being enacted. And so right now we are trying to work on trying to figure out how can we make our prioritization policy more nuanced so that even smaller decisions are made in a systematic way. I'm very, very worried about us putting providers in the situation of having to make those decisions on their own, partially because of moral distress, but also because we have tons and tons of information that says individual people make really biased decisions on irrelevant considerations. And so I would really urge, we're doing it here, and I would urge everybody to think about what does your policy say, and is it sort of an all or nothing policy, or does it take into account the fact that there's a lot of different stages along the way?
That's such an important point, that it's not that there's a thunderclap from above and suddenly it's crisis standards of care. Actually, there's lots of coming up, going back down, coming up, and it may not be the main thing you've been thinking of. It may not be the ventilators, as I think one of the earlier panelists, maybe Adira, that was you, was talking about. There's high flow nasal cannula, there's dialysis, there's all kinds of other things that people who are really sick with COVID need a lot of, much more than your hospital's ready to have on hand on a regular day. Other things, what else would people say? What would you recommend to a colleague who calls you from someplace where things are heating up, or if you see in your own institution things heat up again?
I think the visitation policy should be re-examined. I think we have more experience now, and I think it can be relaxed in an appropriate way without endangering people, because I think that was one essential element of patient care that was missing. I think that's important. I think number two, should there be a surge again, God forbid, I think educating house staff, attendings on some of the policies, some of the approaches that we learned from the first time, to clarify so that there will be more uniformity in certain circumstances. Because when the first surge came, we were going on a day-by-day ad hoc basis. We did not know what the next day would bring. Policies would change, they would evolve. I think now we have a much better feel for how this thing goes. And so I think at the very outset, answering some of the major questions that people had last time and putting it out in some formal statement would be helpful in having a uniform approach to many of these things.
We have a couple of, we have a number of questions left and relatively little time. So hoping see if you've got a succinct answer to important questions. We have a question from Raul Sanchez Leon, who asks, did the panelists have any experience in the formal evaluation of the continuation or discontinuation of salvage therapies like ECMO? I know ECMO was very controversial in quite a few facilities. Do people have comments about that?
Well, we have ECMO. We have an excellent ECMO center here. We did have some patients with COVID on ECMO who survived. I don't think that the policy was any different. We have a very strict and very clear-cut guidelines as to who shall get ECMO pre-COVID and certainly during COVID. I think the emphasis obviously is on likelihood of survivability, and I think that was employed. So I think ECMO is part of the arsenal. It's an extreme part of the arsenal in salvaging patients and saving patients' lives. I don't think that there's a qualitative difference. I think that we did have people come to our hospital from other hospitals for ECMO. But again, I think strict criteria were applied and would continue to be applied as well.
We've had a number of questions about how did the ethics consult teams deal with requests for consultation for non-COVID patients? I know in the peak, some of the New York City hospitals, there essentially were no non-COVID patients. So depends on when you're setting that question. But what comments do people have about that? Non-COVID consults?
Up to this point, our consults have basically been mostly non-COVID related. We've had a couple that have either been complicated by, but we're pretty much maintaining our same normal consult volume and array of issues so far. We'll see how.
So same old in some ways. Any other comments on that one?
I mean, I would say a majority of our consults at the time were COVID related. And so, and I'm not sure why that is. Perhaps staff were managing the non-COVID issues in a way that we've taught and supported them to do over the years, and that the real crisis and the focus was on the COVID patients.
Mm-hmm.
When 83% of your inpatients are COVID patients, you're going to have mostly COVID ethics consults. The other 17%, we had a couple of those as well, and it was a relief actually to have somebody who was not a COVID patient, and we attended to them as we would ordinarily.
I've thought about this a lot because our consults on non-COVID patients dropped so significantly. I think some of it had to do with the fact that people weren't coming to the hospital. I think certain people weren't accessing the hospital, right? We have all this research coming up now that people were having strokes at home, they were having heart attacks at home, they weren't accessing the hospital. I think the other thing to think about is that COVID attacked a lot of our critically chronically ill patients. And those are the same patients that we often get consults about. And so the patients that we generally saw were now coming in were now becoming our COVID patients too. They were inhabiting the same body. So I would say that is something to sort of take note of. But as we think about going forward, I wonder a little bit about some of the situations where people may have taken pause and really thought about a particular patient and their care before, and maybe weren't being as thoughtful because, if we had a non-COVID patient that came in and refused care that wasn't necessarily emergent, they probably got discharged a lot faster during COVID and for the health of that patient in some ways than they might have during regular non-COVID times.
I know we just have 1 second, but
yeah, Janet.
One thing that this question makes me think of is that how many of the questions that we are getting related to COVID are really unique to COVID? How many of them are COVID ethics, and how many of them are normal, same questions that come up just in patients that have COVID? And so I think sometime when we have the luxury of time to look back and see, I think it'll be really interesting for us to see what are the unique ethical questions that came up because of COVID, and which ones are sort of more run-of-the-mill reinventions of the same old.
Yeah. Well, we are coming close to the end of our time, and I'll note that we have lots more questions from the listeners and other ones too. We don't actually have time to answer, but I'll tell you one of the questions that I think we should all think about in terms of ethics consultation. Bioethics in general has focused on individual cases, issues between individual clinicians and patients, and has not really tackled issues that are more system-wide and specifically systemic racism. Can bioethics consultation play a role there? And if so, what is that? So I'm just going to put it out there for like 30 seconds, just to have that in the mix. Any quick comments? Is it something bioethic consultation can tackle? Not really. What do you guys think?
I think by the time the patient is in the hospital and you have the ethics consultation, the systemic issues are above and beyond the ability of the ethicist to deal with. We're dealing with a sick patient who maybe have suffered as a result of societal evils, but our ability to tackle them in a one-on-one situation, I think, is not there. I think it's a whole. Personally, that's how I feel. We try to treat every patient equally, obviously, in the hospital, but I think that these are questions that are above and beyond the clinical consultation service.
Yeah, Adira and Liz. Adira and then Liz.
Okay, I agree to a certain extent that I think bioethics as a field should play a role in this, that we maybe are not situated as individual bioethics consultants on individual cases to make systemic change, but we have to play a role in recognizing the presence of racism in patient care at the bedside. And it exists, in hospitals that serve primarily minority populations. They're not absolved just because everybody in the hospital is from a minority population, or nearly everybody. I think we have a role in recognizing where institutional bias and where personal biases come into play in terms of the way that we interact with patients, how we label them as challenging or difficult when maybe it's really, those are symptoms of our own responses to the patient's race or ethnicity or presentation in a particular way. So I think absolutely there's a role for the clinical ethicists in naming and addressing racism at the bedside.
Okay. Thank you for permitting me to throw a tiny hand grenade into the final minutes there. We are at time, so I thank all our listeners, and I really thank the panelists for your wonderfully thoughtful, empathic discussion of incredibly difficult issues. I invite all the listeners to join us next week if you can, and the following week as well. Next week, our symposium, sponsored by the Empire State Bioethics Consortium, will be called The Importance of Palliative Care During COVID-19, and the moderator will be Tim Quill. You'll have to re-register for that event, even if you've registered for this one or the one before. So I do hope you can join us, and thank you for coming in this evening. And